what we want to talk about today are some of the problems or issues facing hospitals and how we as medical device salespeople have to react to them. And ultimately, we're going to look at an agenda in a moment, but let's first talk about the problem. What's going on in the industry right now for salespeople that are attempting to work with hospitals, whether they're surgical reps or diagnostics or therapeutics? Ultimately, we're facing the same issue. Hospitals are rapidly changing the way they're working with medical device companies. And one of the core reasons is they're attempting to transition from a volume-based delivery system to a value-based system. The reason for this, in terms of where we struggle, the physicians are no longer sole decision makers. In the past, if a salesperson wanted to introduce a new technology, a new product, a new surgical device or implant to a hospital, they approached the doctor, they presented the clinical information, and if the doctor approved it, agreed with it, he or she would then test it on patients, use it in the OR. It didn't require a whole lot of buy-in from the part of the hospital. And again, up until maybe 5 or 8 years ago, the physician would then say to the hospital, whoever the administrator was, I want to be using this particular product on my patients, and the hospital would go ahead and they would purchase it, a physician preference item. Unfortunately, that's no longer the case. And in order to deal with this issue, hospitals are establishing more rigorous committee processes. They're making the decision-making policies more complicated. There's more red tape and more steps in the process. The result of this problem is salespeople are struggling to meet their quotas because they can't navigate through these institutions. And us as companies, monthly, quarterly sales are consistently falling short of projections. Hospital sales cycles are longer, way longer than we expect. And senior sales management in the companies don't have a reliable process for either understanding the deals in their pipeline or projecting, even understanding when something is going to close, because the processes at this point on the part of the hospitals are very much inconsistent and unpredictable from hospital to hospital. So again, that's impacting us in a number of different ways. So now let's look at the solution. And the solution is what we're going to look at as today's agenda, and a number of different points. So number one, we're going to take a look at that changing healthcare paradigm. What does that mean from volume to value? And again, I know a number of you have probably seen that in a number of different professional publications, but we use that term a lot, and we'll discuss that. Then we talk about developing a comprehensive suite of hospital sales resources, the tools, the basic tools that you need in order to sell to hospitals. It used to be clinical literature was enough, not so much anymore, again, because of the issues we just discussed. It's a lot about economics. It's a lot about the bottom line. Number three, we're going to talk about establishing a core economic language and understanding within your sales team. How can salespeople effectively sell to a customer, to a hospital customer, if they don't understand how their technology, how their devices impact that customer's bottom line? If they don't understand the economics around what they're selling, not just their product, but how it affects the rest of the hospital, it's going to be difficult for them to really partner up with that hospital and make an impact in terms of sales process. The fourth piece, we're going to talk about implementing a process for mapping and evaluating hospital accounts and key hospital stakeholders, which is a significant issue because one of the problems we're finding as we coach and mentor salespeople, medical device salespeople, is that they don't have a good understanding of who the decision makers are. And it's more than just one decision maker. It's always multiple decision makers, committees, as we said, processes in place. And there has to be a process for mapping and evaluating these individuals. 5, we're going to look at developing stakeholder-specific strategies and tactics. It's no longer acceptable to have a one-size-fits-all sales approach when you walk into a hospital because you have to deal with more stakeholders now, as we just said, and you need to tailor the information specifically to that stakeholder, and you need to have strategies that are specific to that stakeholder. 6, we're going to talk about optimally engaging salespeople in the clinical relationships and the partnership process. We're finding probably in 80 to 90% of sales opportunities as we work with salespeople, they don't have strong clinical champions. So the concept of not only getting a clinician, a physician interested in your product, but actually evaluating them and then leveraging them in the sales process appropriately. So how do you go about doing that? We'll talk about some of those strategies. And then 7, establishing the sales management process that's strategic, measurable, and most important, accountable. Excuse me. So that's our agenda. for the next 25 minutes or so. So first, we're going to take a look at the concept of, excuse me, the changing healthcare paradigm. And we talked about, as I mentioned, the move from volume to value. What's driving that? Well, we talk about a hospital-centric model today. It's all about everything revolves around the hospital. Everything evolves around bed days. Everything revolves around inpatient admissions. Probably up until about 18 months ago or 2 years ago when the Affordable Care Act was implemented and a number of accountable care initiatives went into place, I think that was the primary goal. Drivers of that transformation, the medical practice changes to focus on coordinated, collaborative care across the continuum, standardized care approaches, care processes that are designed to reduce unnecessary work, optimize service distribution to ensure right care at the right site, and then financial incentives of new value-based payment models. And it's funny because in my perspective or my opinion, I'd say that fifth item of financial incentives probably is, I put that at number 1 or 2, because without the Affordable Care Act, I don't think a lot of hospitals right now would be reevaluating their approach to care delivery. It just wasn't on the radar screen or a high enough priority for them. Certain centers of excellences probably did do that, but for the most part, most general hospitals, even academic medical centers, weren't really focused on it. The result, population-centric model. That's the goal. That's that brass ring or that goal, that end of that tunnel where they're trying to figure out where do we go. It's all about population-centric care, or you'll hear terms like whole population management or entire population management. It's moving from the hospital being at the core to managing the community at large. So not just patients that are critical or patients in general, but how do you manage population health? That's where everybody's trying to move to. And it's going to be a long process. But as we move forward, the goal here is to understand this is the driving business initiative right now for many hospitals. How do you move from the left of this chart, hospital-centric, to the right, population-centric? To make it even more complicated, reduce avoidable costs. So this is an example of probably one of the top issues that hospitals are trying to deal with right now. How do you reduce avoidable costs? And part of it is because of readmission reductions, the penalties, a lot of the Affordable Care Act penalties. It's all about figuring out who's at the top, who's at the bottom. It's all being reported out. So if you take a look, this is a map that essentially shows I call it the worst transgressors in terms of the number of 30-day hospital readmissions for Medicare patients, the rates per thousand. The dark blue states, those are the bottom quartile. So I point out New York, New Jersey, a number of other states more towards the central and east coast, unfortunately, are the worst transgressors of this problem. So if we take a look at what's happening, the challenge now is that we're trying to sell technology and products and therapeutics into hospitals while they're trying to reduce costs, try to figure out how can they be more efficient and ultimately deal with all the challenges they have to deal with. At the same time, they have to recognize that they built these monolithic structures, these 8 to 1,200 bed hospitals in many cases. And I call it, I call it feeding the monster. They have to feed that monster because it has a huge overhead. And the only way to keep that kind of structure going is on inpatient admissions. So as we approach hospitals and we try to partner with them, more importantly than understanding the economics around your product, your technology, is understanding the hospital's business initiatives. On the one hand, they're being forced to move from hospital-centric care to community-centered care. At the same time, they're trying to reduce their costs, reduce readmissions, for which they used to get paid. And at the same time, they're trying to support that huge economic structure, those fixed costs that they've already invested in and don't know what to do with as care starts to move more and more to the outpatient side.